Today, we are covering fall prevention strategies, a critical safety topic on the NCLEX. The exam will test your ability to assess risk, implement appropriate interventions, and evaluate their effectiveness. Let's start with assessment. The NCLEX expects you to use a validated tool like the Morse Fall Scale. An exam question won't just say a patient is a fall risk. It will give you clinical data and expect you to draw that conclusion. For example, you might see a 78-year-old patient with a secondary diagnosis of osteoporosis, an unsteady gait, and a history of a fall at home last month. Your first mental step is to recognize these as key risk factors on a standardized scale, immediately flagging this patient as high risk. This initial assessment is always the first step and often the correct answer when you're asked for the priority action. Now, let's talk about interventions, specifically how the NCLEX tricks you. The key principle is to always choose the least restrictive intervention first. A question might present a confused patient who keeps trying to get out of bed. The options could be applying wrist restraints, administering a sedative, raising all four side rails, or implementing hourly rounding. Applying restraints or giving a sedative are chemically and physically restrictive, and almost always wrong answers for fall prevention. Raising all four side rails is considered a restraint and can actually increase the risk of injury if the patient tries to climb over them. The best answer is hourly rounding to address the patient's needs for toileting, pain, or repositioning proactively. Another common exam trap involves medication. The NCLEX wants to see that you can connect pharmacology to fall risk. Be on high alert for patients taking diuretics, which cause urinary urgency, antihypertensives, which can cause orthostatic hypotension, and any psychoactive drugs like benzodiazepines or opioids. An exam question might state that a physician has just ordered furosemide for a patient with heart failure. The question will ask for the nurse's priority action. While administering the medication is important, the priority from a safety perspective is to update the fall prevention plan. Ensure the patient knows to call for help to get up, and perhaps place a bedside commode. A great way to remember the key components of fall prevention is the mnemonic SAFE FALLS. S is for screen for fall risk using a validated scale. A is for assess the environment for hazards like clutter or poor lighting. F is for follow protocols like keeping the bed low and locked. E is for educate the patient and family. The second F is for footwear, ensuring non-slip socks or shoes. A is for alarms, using bed or chair alarms for high-risk patients. The first L is for least restrictive first. The second L is for look at medications. And finally, S is for scheduled rounding. What happens if a patient falls despite your best efforts? The NCLEX will absolutely test you on this. Your immediate first action is never to call the doctor or fill out an incident report. It is always to assess the patient for injuries. Stay with the patient, call for help, and perform a rapid assessment, checking for level of consciousness, vital signs, and any signs of injury, paying close attention to the head and hips. Only after the patient is stabilized do you notify the provider and then complete an incident report. The incident report should be a factual, objective account of what happened and your assessment findings, with no blame or speculation. This sequence of actions, assess first, is a core nursing principle and a frequent topic for NCLEX priority questions.